This lecture was originally given for the Airway Academy on October 3rd, 2025. The lecturer and myself, my name is Dr. Mark Allen Podolsky, and I am with the Atlanta TMD Institute. The title of our lecture today is Airway and Temporomandibular Disorders. This is a really interesting subject, and in fact, I believe strongly that they're integrated together. They have the same origins and difficulties, and I can show that pretty much, hopefully, through this particular lecture. I have no major conflicts or any conflicts of interest to announce other than I am the owner and founder of the Atlanta TMD Institute, author of several TMD books. The Institute, educational aspect of the Institute is nonprofit. We provide textbooks and also courses on TMD, reasonably priced. And the clinic itself is for profit. It supports me so that I can live. And some of those profits do go towards supporting the educational aspect of our institute. Probably the most favorite person that I admire is Winston Churchill, Sir Winston Churchill. If it wasn't for him, there's a good possibility we could all be speaking German, and I probably wouldn't even be here. But anyhow, one thing that Churchill said was, out of intense complexities, intense simplicities emerge. And that's going to be important to remember, because as you're learning all this stuff about TMD and airway and all these related facts and figures, and it's hard, how do I apply it in the clinic, what's significant, what's not significant, all these things will take shape as you learn the material and apply it to your patients. Just be patient with yourself. Understand you're going to make mistakes. Understand you're going to be confused. You're not a perfect person. No one is. So please understand this very important principle and be patient with yourself. One of the most interesting things that just rings a bell is something that Max Planck stated. He was a Nobel Prize physicist from Germany. He said, "A new scientific truth does not triumph by convincing its opponents and making them see the light, but rather because its opponents eventually die and a new generation grows up that is familiar with it." And that's what TMD is about right now. There are competing forces, old philosophies, people who are entrenched in doing something for many, many years don't want to change, and they're not going to change. They will continually attack, and this is part of mankind's natural nature. And I have to accept this. And perhaps this information that we're presenting will become routine in the future, but perhaps not now. But I hope that you'll learn it and use it in taking care of your patients. I'm going to make some really powerful statements, and hopefully you'll fully appreciate them. First is pediatric airway disturbances in children, temporomandibular disorders, which I treat every day, and obstructive sleep apnea, treat them also, all have many of the same etiologies. So etiologies are essentially the causes and origins of a disease. So, and that etiology springs forth different signs and symptoms. You'll see that many of these signs and symptoms overlap because they have similar etiologies. Most of the temporomandibular disorder and OSA patients that I see today were really untreated pediatric airway cases during their childhood. And sometimes they were treated, but it didn't work. They relapsed. It was a failure. So one of the things I want to point out is that treating kids, from 3 to 8 particularly, when they're developing, this is the very best time to correct the craniofacial system, the entire morphology and function of the child, because that child, if placed on the right track, will ultimately, in most cases, develop into a healthy adult. This is not a new concept to me. Back in July 29th, 2022, I gave a lecture before the Academy of General Dentistry, and the title was Obstructive Sleep Apnea and Temporomandibular Disorders. Are they the same? And what's the dentist's role? And this was a very important lecture. We had good attendance. I'm not sure everybody got the data and applied it, which is great concern. That's part of the problem with teaching. You present the ideas, they may not click in for years after, if they ever do. So I'm hoping that you guys will be like sponges and learn all this information, re-listen to everything, re-watch everything, and become as educated as possible to help your patients, because this is very important. I like to think that I'm a scientist, and I try whenever possible to basically establish my thoughts based on true data, real stuff that's true, right? And the first starting point related to the human morphology is bone. And we have to look back at Wolff's Law of Bone. Now, what is Wolff's Law of Bone? Bone is in a healthy person or animal will adapt, that's the key word, adapt to the loads under which it is placed. If loading on a particular bone increases, the bone will remodel itself over time to become stronger or to resist that sort of loading. The internal architecture of the trabeculi undergoes adaptive changes, followed by secondary changes to the external cortical portion of the bone, perhaps becoming thickest as a result. And this is a really, really important law that we forget. Bone is plastic. Now, it doesn't change overnight. It literally takes months and sometimes years. I think the skeleton turns over every 7 years. So bone is an active tissue. It is not dead. It's not a dried tissue like we think when we're looking at dried skulls. It is a very efficient tissue. It responds to the loads applied to it, and it increases its architecture to deal with the loads as the loads are presented to it. And then it will change if necessary. Now, if we take Wolff's Law a little further, which Dr. Melvin Moss did, he postulated a new theory. It's called the functional matrix theory. And basically, he divides the body up into functional units. Function is very important because the movement has purpose. It is there to create pro-survival. Movements that enhance the organism's ability to survive. And almost every movement has a major purpose, and it assists in living. And basically, he said that the bones and the tissues will form around that function in order to allow that function to be efficient. So the body changes based on its function. And that makes sense. Like if you're lifting weights, there's going to be a change in your bone structure, and there's going to be change in the muscles. Everything's going to grow in that area. Likewise, if you put someone in a cast, they don't move for 6 to 8 weeks, it's all going to shrink. But the functional matrix theory states the origin, development, and maintenance of all skeletal units are secondary, compensatory, and mechanically obligatory responses to temporally and operationally prior demands of related functional matrices. So if you divide the body into little segments and there's some sort of function there, the body will adapt and improve and change in order to make that function occur. This is a new concept. We used to think about, well, the size of the face was determined by mom and dad. Instead, there's something now called epigenetics, meaning that genes turn on and off based on their environment. This particular theory meaning If bone responds to its function, it's going to change shape and size. This is an interesting concept, and I absolutely believe it. You know, I'm a show me guy, right? So, okay, you invented this functional matrix theory. Well, show me where it works. Well, interestingly, Inca liked to look like space aliens if they were nobles. So the nobles bound their children, their head, so it would grow into a cone head, and it was a sign of nobility. So you can see here to the left that those skulls are not normal. Why? Because they were bound. They were limited. So therefore, the external environment changed the way the bone functioned and shaped. Next, we have an African woman. They're putting rings on, and look how long her neck got. Because of what? Because of the stretching motion of the rings. The rings, the pressure from the rings, changed the shape of the functional matrix, the bone and tissues. So basically, bone changes shape in response to the pressures applied to it. This is kind of a key critical concept that you want to keep in mind when you're studying TMD or any other area in dentistry. So the last two examples were pressure inward, but how about pressure outward? Well, this is where the cerebral aqueduct in the brain gets blocked and internal cranial pressure increases, and you get this huge enlargement of the bone. What is happening? The bone is responding to the pressures applied to it, the function, in this particular case, abnormal function. Again, I compound over and over and over again proving this theory because I want you to think functional matrix theory. Melvin Musk, who was in fact a dentist and a PhD anatomist. But here, you know, I think the Chinese, maybe the Japanese, bound the feet of women in order for it to look sexy. And they literally, if you see the way all the digits are, you know, twisted, and that's from being bound. So again, proving the Wolff's Law of bone and the functional matrix theory. So you say, well, that's great, doc. Show me how I can use this in the clinic and make my life easier. And I think it's important to understand always what's going on, and so that you can control it the more you know about it. Here we see a palatal expander on pediatric teeth. At one point, I kid you not, orthodontists used to believe that you can't move pedo teeth. That's not true. You can move them. And you can expand the palate using pedodontic teeth. It's very interesting. So here we have proof of that, and we have a adjustment expander that allows growing the entire palate and dropping the palate downward if it's done slowly. This is a very important thing. You should always mimic nature because nature knows best. Evolution knows best. The biology is there and things happen because of the biology. And if the palate grows over like literally 5 years, shouldn't you go slow rather than rapid? So a lot of people, a lot of orthodontists particularly, they put these things in on 13-year-olds and they jack them 2 twists or about a 0.5 millimeter every day until the palate breaks. I just don't think that's natural. I don't think it's good either. I want to go more slowly with 1 turn like every week, 1/4 of a millimeter every week, just mimicking nature as best as possible. But again, this is what we see with pediatric airway, and it works really well. It increases significantly the ability of the patient to breathe. And there are a whole bunch of signs and symptoms that improve from doing this. So that's why we're doing it. However, we need to step back sometimes and say, how would nature do this? Is that going to be better than what we're doing? And the answer is yes, because as you expand, if you do it too quickly, the shape of the palate stays but breaks in the middle. If you do it slowly like nature and encourage the tongue to swallow, the palate drops down, making the nasal area bigger also. Isn't that nice? So Theodosius Dobzhinsky is one of the most amazing people, and I have applied his datum to everything. There's always a purpose to the movement that we see for muscles. There is a purpose to the shape and form of each parts of the body. Everything makes sense based upon giving the ability to survive. Evolution selects survival patterns, both physically and behaviorally. And he said, nothing in biology makes sense except in the light of evolution. And so I apply this continually whenever I'm doing analysis of why something occurs, like head position or whatever it might be. Why does the cervical spine have problems? Well, because it's in charge of making sure that the head is level. And if the head's not level, it's going to distort itself to make the head level. There's a purpose. There is something that is definitely the reason for it to occur. So again, whenever looking at things, apply this. Nothing in biology makes sense except for the light of evolution. What evolutionary advantage was given, even on the molecular basis, and that's true right to the molecular basis. Why is that pathway chosen? And it'll lead to the right answer, always. This is Louis Sullivan, and he was one of the most amazing people. He was one of the first people. This is the first skyscraper ever to be built. And he had a statement. He said that form ever follows function. And this isn't really true evolutionarily also, that the form of whatever something is must be based upon the function. And it has to do with skyscrapers, and it has to do with human bodies also. It's just a construction fact. So before I even get into this airway course, I have to really emphasize something. We're focusing on airway because it's lecture, but it's a small component of TMD. Temporomandibular disorders have many different etiologies and causes. Okay, very important. TMD is multifactorial, multi-causative, multi-expressional. Two people can have the same disease in their joints. One's in pain, one's not. It's multi-interactional, and it has many different causes or etiologies. Today, mostly we're looking at airway compromise, but growth and development disturbances, postural imbalances, endocrine dysfunction. Now remember, the cells are what are responding. And if they need a hormone to grow properly, hormone's missing, it's just not, it won't work. They won't respond the same way. Macro trauma, repetitive micro trauma, which often destroys the disc in the joint. Vitamin insufficiencies, chronic disease states, sleep deprivation, that's everyone. I'm going to say almost all of my pain patients are in pain when they sleep and they wake up. Psychological stressors, spinal degenerative conditions, particularly the upper cervical spine, connective tissue disorders. We just had a patient today who was never diagnosed and had lots of problems, even kidney operation, and arthritis. So osteoarthritis, rheumatoid arthritis, and several other causes. So be aware. I'm not making this simplistic. I'm just giving you one viewpoint. So John Hickam, MD, made a statement which is so important. A patient can have as many problems as they damn well please. This is very important. So you come up and you say, oh, I found this, I'm so smart. And it turns out that it's one of 3 or 4 things, but you found one. And very often we tend to be limited, I call it dental myopia, because we tend to think about teeth and joints, but we don't think about all medical issues and other things that could be overlying. And Dr. Hickam made this, and I always, it was taught to me by Joe Councilman, who was the chairman of the oral medicine department at Emory. And whenever I see patients, I'm looking for multiple causes and different things. So I sort out the symptoms and ask, where do those symptoms come from? And sometimes it will lead me to 2 or 3 different things. A good example would be undiagnosed thyroid disease that has a normal TSH. So you can have a normal TSH, but has Hashimoto's thyroid problems, or you could just have an enzymatic problem that prevents you from making T3 from T4. But there's just a lot of reasons why you can have a normal thyroid problem with all the signs and symptoms of thyroid disease. But we always want to keep our minds open whenever we approach patients, and remember that it's not just a dental problem that they may have. There may be other problems. One of the things that really worries me, and I'm serious, I see surgical cases every day. I see mistreated cases with appliances that are inappropriate. I hear people going to physical therapists or chiropractors over and over and over again. I just don't know. It's just an amazing thing. Most dentists know nothing about TMD, and that is absolutely true. They dabble in it, but they don't know what they're doing. They don't know the physiology. They don't know the pathophysiology. And they call and ask their laboratory technicians or other dentists, well, what appliance do you use? I had that happen this weekend. And it's a huge insult because they think that, if they make the right appliance, magically, like a special pill for Alice in Wonderland, everything would get better. They then place Band-Aids on their TMD patients because if they put like an upper appliance that's flat, it may decrease some of the symptomology, but it won't cure the problem. The problem doesn't go fully away, and they don't really look. And they never really treat all the TMD signs and symptoms. And one of the first things we see is, Dr. Podolsky, what appliance do you use? Right? A well-known dentist just in the past week asked me, well, what appliance do you use and how do you make it? And it's like, oh my God, it's making simplistic because I use many different types of appliances depending on the problem that is being observed. So although TMD has many different causes, many etiologies, I'm going to say that the most common etiology has to do with airway. So here it says the nasal airway becomes obstructed by swollen nasal turbinates. These are, if you look down on the lower right side, those are turbinates. They swell up and you can't breathe through that nasal area. It occurs from swollen adenoids and swollen tonsils. These are all lymphoid tissues. They protect the body. So they swell when they're fighting things like allergens or pollen or other type of stuff. And it's primarily from airborne allergens and irritants, including molds, and secondarily, although I'm learning more and more, from food allergens. Food allergies are amazing, and 40 years ago, I would talk about them, and doctors like allergists would think I'm crazy. They didn't believe in food allergies. But now we have people that are having gluten sensitivities and celiac disease and all kind of weird stuff. And physicians are now very much aware that allergens, food allergens, cause lots of problems and will cause inflammation in your gut, leaky gut, and it will open the doors so that stuff from the bottom part of your gut goes up to the top, all kind of stuff that creates problems. But the patient also, because of the nasal obstruction, they have no other place to go but breathe through the mouth. And mouth breathing is toxic. The patient becomes a mouth breather, and most often a partial mouth breather. And I say partial because they may not show the allergies all the time. Their mouth might be closed. There have only been a few times in my life where someone has walked up to me and given me a book and said, you really need to read this book. And a gentleman, a fellow dentist, John Hughes, has passed away, handed me this book, Stigmata of Respiratory Tract Allergies. I read it, and I'm telling you, I never returned. I was never the same type of person, because he just revealed so many crazy things. First of all, allergy will cause malocclusion. If you look at the jutting forward jaw on the left-hand side, Dr. Meyer Marks used to lecture to orthodontic societies and all over the place. People never really paid much attention to him. And one of the stigmata, or the bad things that happen from respiratory tract allergies, is malocclusions. How do you like that? And he has that's pretty much established. Lots of papers. And what's really crazy is this area on the right side related to the eustachian tube. Now, the eustachian tube, if you look, goes from the back of the nose all the way to the middle ear. And the middle ear is a little box, and on the outside is the ear. So if you have your ear hole, you hit the eardrum, and then you got the middle ear. If that sucker doesn't drain very well, your kid is going to try to grind, because when you swallow, you pull open the entrance in the bottom right of the eustachian tube. So let me repeat this. When you swallow, you open your eustachian tube. If your eustachian tube is blocked from allergy swelling, you're going to try to open it by doing what? By continually grinding and swallowing. So kids at age 2 grind and swallow, and they make noises at night, and they flatten their teeth. And when they flatten their teeth, their adult teeth come up to a shorter height, because all that tooth structure was ground away from the pediatric nocturnal nighttime bruxism. I love reading panoramic radiographs. And when you look at the area above the front teeth, you've got the nasal area. And in this particular case, the septum is straight but swollen on the top, and there is very, very little black area. This poor kid, this poor lady actually, cannot breathe. And where's she going to breathe? Mouth. Now, if you look at the teeth, it looks like the lower teeth are dumped forward slightly, and when she bites, she has an anterior open bite. So her tongue has been taught to stay down. So in other words, if you can't breathe through your nose, where do you breathe? Through your mouth. Now, is the tongue in the way if you're breathing through the mouth? Yes, it is. So your brain programs it, what they call it engram, and it programs them to stay down. So every time you want to bring your tongue up, it won't let it do it. It thrusts forward, opens up the teeth. Now, interestingly, she has flat teeth, anterior open bite, but look at that stylohyoid ligament. Holy shoot. On both sides, it's just one of the longest I've seen. And you need to start looking at that, because almost always stylohyoid ligament calcification precedes osteoarthritis. That's the facts, right? Studies and studies. That's the facts. So we're going to have osteoarthritis in the future for this person. I probably shouldn't joke around, but I really get upset when I see things like this happen. And the first thing is, you look at the nasal area, it's obstructed completely. This person also, if you look, has an anterior open bite. Again, lowered tongue posture to breathe with the mouth. Why? Because you can't breathe through anything. There's no space at all. So they put the braces on to correct the anterior open bite and to straighten everything. But boy, this person has been grinding too. If you look at the bottom of the mandible, it's called anti. Anti means before, gonial on the edges, antigonial notching. That's masseter spasm. Oh my God, masseter's been grinding away. As I told you, a person that has ear issues is going to grind. A person that has sleep issues also is going to grind. So when they put their tongue forward, what does that do? It takes the back of the tongue out of the throat, so then they can breathe. In this particular case, there's no way, no how. This person should have had nasal care first, allergy, nasal, then maybe opening surgically, which I hate doing, but this is one of the worst blocked noses that I've seen in my entire career. So as I said, airway is probably the number one etiology. It's the most common etiology. Etiology means the cause. So I'm going to read on the right side. It says, to breathe through the mouth, the nasally obstructed patient's central nervous system, this is your control system that it does everything for you, breathing, sleeping, pooping, digesting. It does everything for you. You don't even know it. So the obstructed patient's central nervous system programs the tongue to remain lowered to improve oral respiration. It's called the lowered tongue posture, and it gets the tongue out of the way through the breathing hole, right? Normal people don't do this. Normal people breathe through the nose. That's critical. Because of the lowered tongue posture, the airway patient develops a chronic lowered tongue posture, stays down, and an abnormal swallow. In order to swallow, you must be able to put the tip of your tongue right behind your front teeth, and then your tongue goes up against the palate and squeezes everything back like toothpaste, and that's a normal swallow. So if you look at the diagram on the left, the top says correct. Notice how the red tongue is pushing up against the palate completely, front to back. With the anterior tongue thrust, lower tongue posture person, they do not put their tongue up on the top of the palate. They don't, because the brain says, don't do that. You're not going to be able to breathe. And so it's so interesting. You can test this by asking the patient, please put your tip of your tongue on the top of your palate. Don't touch your teeth. Keep it there. Close, put your teeth together. Keep it there. Now, can you swallow without opening your mouth or moving your tongue tip? And almost all of these TMD patients can't do that swallow. And that very often has to be rehabilitated too. But if you don't know it's there, you can't correct it. So why do upper dentures stay up? Why don't they just fall down? And you say, well, because of the suction. You need a good seal around your denture to get a suction, right? Well, this is a very important thing you need to know about. It's called the space of Donders. Dr. Donders, like 150 years ago, found this. He said, when you put your tongue up against your palate and seal it inside your teeth on the edges, and then the weight of the tongue drops, it causes a vacuum in the middle. So the vacuum area between the dorsum of the top of the tongue and the hard palate, when the mandible is in its resting position, there's a vacuum there. And then your patient should always have the tip of the tongue in the front at rest. So the mandible is open. This diagram sucks. Typically, your mouth will be slightly open, your tip of the tongue on the top of the palate, and there's a suction there holding the upper part of the tongue against the palate because of the suction. And that also means that there's constant pushing forward and side to create that seal to keep the tongue there. And if you go back to when we were talking about the functional matrix theory, that pressure from the space of Donders vacuum against the teeth and palate, forward and side to side, makes the upper jaw grow. The maxilla gets bigger. Plus swallowing all the time makes it bigger. These are normal stimulations that people that have lowered tongue posture do not have. I love it when people argue with me because then I can show them pictures to prove my point. Here, the airway obstructed patient's tongue does not rise when swallowing. It does not press into the palate and the maxillary alveolar process. Remember I said that's what causes the growth, the pushing out of the tongue during rest, during space of Donners, with pressure and swallowing continually. Up, push against, make it bigger. Well, guess what? If you don't have a tongue and this person does not have a tongue, then look what happens. It can't grow. It cannot be expanded. The tongue is necessary for the expansion. For the lack of stimulation, the maxilla does not grow laterally, and I got to point out in red, anteriorly forward because of the absence of tongue forces. This patient has no tongue. There is no growth because there's no stimulation, there's no force on the bone. Wolff's Law cannot be applied because there's no pressure onto the palate. Just to make my point again, look at this palate. This person does not have a tongue. It's called aglossia, and the maxilla is itty bitty. The mandible is itty bitty. You see the mandible on the bottom? Look how small it is. No tongue to hold out the teeth. No tongue to stimulate the growth. And deep bite. And just narrow. Everything is crazy. What is the moral of the story here? No tongue, no normal swallow, no space of odontor and rest on the palate, no development of the maxilla. Maxilla guides the mandible. I'm going to repeat that. The maxilla guides the growth of the mandible through interdigitation and mutual interaction. It does. So here we have proof that that tongue is necessary for maxillary growth. And almost always, these patients have undeveloped middle faces, what they call A point in orthodontics is too far back. The maxilla is not forward enough, not developed enough. It's just been so common in the United States. We see these things, we don't recognize them because so many, like 70% of the people have a class 2, and they're all underdeveloped. I think it's really important to know your anatomy, the relationships, what's next to the ear, the joint, the jaw joint, what's next to the nasal cavity, the palate, all these various things. Very important stuff to understand. So because the palate does not descend, the floor of the nasal cavity does not descend. So the floor of the nasal cavity is the roof of the mouth. It's the same bone. And as you stretch the palate laterally and anteriorly, it brings the high palate down flat and it opens the nasal cavity. You look on the right side, see those downward arrows? As the palate on the top drops slowly, the base gets bigger and the height gets bigger, which means that nasal cavity volume depends upon the descent of the palate. They used to think that the nasal septum caused growth, but then they would obliterate, in studies, obliterate it and would still grow. It is not the septum that causes nasal growth. It is the tongue. The entire midface is controlled by the tongue and the maxilla dropping and expanding forward and back. And the lower jaw, if you remember, we were looking at aglossia, the lower teeth fit into the upper teeth. The lower teeth follow wherever the maxilla is. Remember this, the lower teeth, the mandible, will fit into the maxilla wherever it is because they interdigitate and they lock together. Got it? Growth of the mandible has to do with growth of the maxilla. Growth of the maxilla has to do with tongue function. Growth of the nasal cavity, tongue function. These are all very important stuff. So the nasal cavity does not enlarge laterally or vertically because of the lack of proper tongue. There's not enough vertical room for the nasal septum to grow downwards, so it will deviate or bow. It will keep on growing with not enough room because the tongue never dropped the palate. Got it? Very important concepts. Take a moment to think about this. Just an important concept. I hope you'll get this. I hope I can explain it. When you expand the palate and increase the size of the nasal cavity, you make more room for the swollen turbinates. The turbinates are still swollen, but the actual nasal cavity is bigger, so you can breathe better. It's not because you took care of the allergies, it's because you made basically the nasal cavity bigger. But the same allergenic swelling is still there. This is why most pediatric asthma patients grow out of having asthma attacks. The tissue swelling is still there, but the bronchi are much bigger. So let's just basically say that an itty-bitty little girl here with her beautiful red nails, she has a very small bronchi, and it swells inside there, let's say 5 millimeters. So, okay, if she's a little girl, small bronchi, 5 millimeters is a lot. Now she grows up, she's got big, giant bronchi, 2-3 times the size. She's still swollen 5 millimeters, right? Still swollen, still allergenic, but because the bronchi are bigger, she can breathe. And so we see, they say, oh, your asthma's gone. No, it's not. It's still there. You take that same person, make them run or do some other stuff, they can't function. So what's really important is when you're expanding someone, you're making them bigger. That's wonderful, guys. They immediately do better. We know that statistically, they sleep better, they feel better, but you still have that underlying causation of the allergies, and they must be taken care of. And otherwise, you're going to have recurrence when the person gets older. Most likely, they'll have TMD problems. Most of us had to take CPR, keep our licenses. Well, what do you do with Annie's head? You extend it backwards, head tilt, chin lift. Why are you tilting the head back like that? To open the oral airway. Notice when we do CPR, we're breathing through the mouth, not the nose. The mouth is bigger. We can put more air into that mouth, but in order to get it open, we need to extend it up and back, as we see on the right side. Well, what happens is the child can't breathe through the nose, they breathe through the mouth, and they immediately rotate their head back to open their oral airway. They're trying to breathe through their mouth better. So the mouth breathing nasally obstructed patient assumes a CPR, mouth-to-mouth, head tilt, chin lift posture. Rotate it back, I can breathe better. But then the brain's not going to let the eyes look up at the ceiling. So they're going to throw the whole top of the head and the neck forward and create a forward head posture. The patient postures the head forward to keep the oral airway open and maintain a horizontal visual field. And this creates all kinds of problems for our children. This little girl is breathing and probably snoring, which is totally abnormal for a child that age. So I'm going to do a brief demonstration. If you're sitting, stand up. So what I want you to do is hold your nose. Now you got to breathe through your mouth. Rotate your head backward. Now you can breathe better. Now take your whole upper neck and shoulders and bend them forward, looking straight. Notice your shoulders have come inward, scapula have come up, your clavicles have bent up and forward, and you have a compressed back of the neck. This is an airway maintenance forward head posture. You see it, you know it. Kids forward, rotated forward. It's also going to cause slower lower jaw growth because the muscles are pulling back on the lower jaw. So a lot of weird things happen. So just watch your patients, particularly kids, because these kids can be treated and got right back onto a normal pathway. When you have a forward head posture, it takes the weight of the head off of the center of the body, and it makes it much more difficult to hold it in place. The effort actually increases tremendously. So a 10 or 12 pound head straight over the center of the body weighs 12 pounds. But as you come forward, it multiplies the amount of pressures. Notice how his neck is going forward. It's going to change the way the vertebrae are, but it also increases the experienced weight from 12 to 32. And when it is super forward, even forward to the center line, it's 42 pounds. You know, a human body was not designed to carry this kind of weight for a lifetime. So you start seeing degeneration in that cervical spine. You start seeing all kind of stuff. And of course, this is the older lady coming in to church with a cane, walking forward, bent forward. And this is from, believe it or not, airway, TMD problems, all kind of stuff. I believe that most forward heads, if not all, are related to respiratory issues and mouth breathing. And that causes a lot of the TMD symptoms later in life because as the person grows, they don't grow correctly. Everything's distorted. The anatomy is distorted. Of course, an axle on a car that's bent is not going to work as well. And the same, a body that's twisted is not going to work as well as a normal body. So Egil Harvold, I think he was the University of Michigan, he said, okay, let's take plugs and put it in human kids. And they said, no, you can't do that. You can't do that. All right, well, so we'll put it in rhesus monkeys. And so he did what's called primate experiments in oral respiration, breathing through your mouth, put Teflon plugs, and these faces all got twisted. The breathing changed to different types of patterns. Lots of bad things had occurred with the face. It's an actual experiment. It's in the American Journal of Orthodontics. It came from the orthodontic literature. Yet, do orthodontists watch and look and see how allergies affect or blocked nasal passages from allergies affect the teeth that they're moving around? This is just another few photographs taken from Dr. Harvold's experimentation. But how can you argue when you have such solid evidence? They put the Teflon plugs in the monkey noses, and then the monkeys grew facially. They had what's called adenoid facies, the whole face distorted, the mouth, they're breathing through their mouth all the time. Watch your patients. Do they come in with their mouths open all the time? Very important. Was a study, and I can't quote it. I believe it was a Tufts, and they had like 300 kids, and all nasal blockage, allergies. 100 they left alone. The other 100 they just did tonsils and adenoidectomy, and the third group tonsils and adenoidectomy with ortho. And they followed these kids over like 10, 12, 15 years, and it was so interesting. The ones that had the nasal allergies, their faces grew like this. Oh my God. Then the ones that had a tonsil adenoidectomies, they grew relatively nice. What was interesting was it's unethical to tell these mothers you can't get a TNA, tonsil adenoidectomy, on your child because you're part of a study. Because sometimes they would go and have their child have the TNA, and then the face restored to normal. Oh my God. So it was growing improperly, badly. They had a TNA, which they were not planning to have, the face restored. It's craziness. We are definitely, as Moss says, a functional matrix. Our entire body can change with time. We used to think when I was a kid, oh, the brain has so many cells and that's it, you're gone. Nope. That was a myth. The brain does have neuroplasticity. The body is meant to change. I don't like the name adenoid facies because it's not just the adenoids that causes nasal blockage. It's turbinate, hypertrophy, tonsils. Taking adenoids out is easy, but most doctors don't want to do it. ENTs, they don't get paid very well. And certainly doing a tonsil and adenoidectomy now, they don't like doing it. They don't get paid well. It's just a problem. I don't like it because it's adenoid, that whole Waldeier's ring protects the mouth. It's the defenders, and they're just swollen because they're in fights all the time. But when you see this long face, the mouth is open, that is mouth breathing. And you get the V face, you get open lip posture, you have a hypoplastic small maxilla, you have ear infections and all kind of stuff. These kids have tubes, they can't sleep, they have a dull mask face, crowded teeth. And then if you look on the bottom left, these are sisters, and I'm going to talk a little bit about the sisters. But look up adenoid facies on Google and just look at all those pictures until you got it. Open mouth, number one. Number two, the V-shaped face, elongated face, no cheeks, right? And they do allergic salutes right in front of you. There's a whole bunch of stuff that you should know this and recognize it in kids immediately. As soon as they walk through the door, you don't have to open their mouths. So these two young ladies are sisters. One got treated by Dr. John Mew in England, and the other did not. For one reason or the other, did not. So again, we're going over airway as the most common etiology. While mouth breathers' craniofacial characteristics become deformed. We got an angelic, beautiful kid on the left side who breathes normally and was treated with functional appliances. Well, on the right, young lady was not treated. So this sister looks tremendously different, and I would argue that the girl on the left side looks much more beautiful than the one on the right. The left side was treated, right side was not. The right side is a mouth breather. I have this slide in to show the winged clavicles. So a mouth breather's craniofacial structures become deformed. We showed that with the two sisters. We see the adenoid facies. There's absolutely a relationship. The patient's clavicles elevate. The suboccipital region becomes compressed because the head's back, and the submandibular muscles pull the patient's mandible backward like an elastic or a headgear to compress the temporomandibular joints back and against the ears, and it retards mandibular growth. That's why we see so many class 2 skeletal patients. Many of these children have headaches and neck aches, and they ignore them. The pediatrician ignores them. Oh, it's growing pains. It's okay. It's not. It isn't. Clavicles should be, like on the left, horizontal. If you look at the guy in the middle, he has his wing clavicles. Got it? And the physiotherapist treated him, and he has a much better head posture, huh? But look at his clavicles are lowered a little bit, but not that much after physiotherapy. Those wing clavicles tell you nasal problems. So earlier in the lecture, I told you what causes the maxilla to grow outward, forward, laterally, opening the nasal area. What causes that? A proper swallow, a proper tongue function. So what is the elephant in the room causing all these problems? The tongue. And Einstein loved to stick his tongue out. He's still a child. I'm still a child. Absolutely. I refuse to become an adult because adults are unhappy. Kids are always happy. They're into everything, and I'm into everything, and I hope you will be too. This is all part of a wonderful life and a wonderful career. Please always just think about your patients, ask why things happen, how you can intervene and recognize things, and you'll just be a much happier person. I always get a kick showing this slide because these are real tongues and they're part of Ripley's Believe It or Not. So tongues can be pretty amazing. So I think it's critical understanding the Moss's theory of growth and development from stresses and looking at Wolff's Law of bone. The movable part of the body, the soft tissue, creates the architecture. And the tongue serves as a template. It forms the maxillary arch through swallowing, through relaxing with a space of Doppler vacuum, pressing continually outward. This forms the upper arch, and then the upper arch is a template for the lower arch. Lower arch follows and interdigitates with the upper arch. That is a functional absolute priority. Maximum intercruspation is neurologically programmed. It's a specific spot in three-dimensional space, and the body knows it. And it comes through all of these computer program systems and neurological circuits that we have. We always want to think in 3 dimensions. We want to think function. So it's extremely important to say, okay, if the tongue is the template and provides the forces for growth and the shaping, what other considerations are there to understand? So you must treat the maxilla the same way that nature does, okay? So when a person swallows, they don't just swallow in the back, which is what most airway dentists think about. They put their bands on the back, they expand in the back posterior area, they open the bottom back of the nose, and the person breathes better. But guess what? There are other dimensions, other spaces that can be created, and it's very important. And if you look, I have one dimension, simple thinker, posterior, but wait a minute, how about anterior pressure? When you're an airway dentist, how are you getting that anterior development? When you look at the side of the person's face, you look at where that is, almost always there's some maxillary deficiency. But these are two dimensions. And in fact, in a complex world, the real world, we're thinking vertical also, which very often, orthodontist dentists don't think about vertical, even with their dentures. Sometimes they'll just keep on repeating the same vertical dimension for a person who's wore dentures for 20 or 30 years as the patient has ground down their teeth, of their prosthetic teeth, and as the patient has lost their alveolar process, and they just collapse the face. I always like to compare and contrast and pull different aspects of dentistry or medicine in to relate what I'm talking about and what I'm thinking about. It's very important. So the medical literature is clear. It often refers to dental sleep appliances. Get this, mandibular advancement devices. So these appliances are all pulling the mandible forward. And if we look at this cross section, by pulling the mandible forward, we're opening up the posterior airway space. It's really important. If we look up at the palatine tonsil area, if we move that entire maxilla forward in our functional appliance therapies, or by trying to keep good nasal breathing in children, we're going to be opening up the back, we'll be opening up the nasopharynx also, in addition to the oro and hypopharynx. These are key concepts in understanding, treating patients, and understanding the anatomy and the function. So again, in review, advancing the mandible pulls the tongue out of the throat. Advancing the maxilla, which is a bony structure and done with children, hopefully 3 to 8 years old, or naturally by opening the airway, we're pulling that entire maxilla forward and opening the back of the throat, which allows for a wonderful curve in the actual cervical spine bones, because you can see the bones of the posterior limit of the airway. So here's a critical concept I'd like you to sit back. You're thinking about moving anatomy around. You're playing your Einstein imaginary experiments, and you're moving things around. But here's a critical concept, something that you must really understand fully. If you have to advance the mandible position forward to facilitate breathing, then this forward position, by definition, because it works, and by clinical practice, because it works, is in fact the natural, most physiological position of the mandible. Cause, time to think. Are these mandibles in most of our patients retrusive? Yes. Are they at most skeletal class 2? Yes. Is the maxilla compressed backward? Yes. What's happening? The growth and development of our patients is disturbed, and it comes from many different things: allergies and airway, lack of chewing proper foods that cause you to chew, which we don't do. Everything is pre-digested, pre-processed, so that there's no real work in ever having to chew anything. So we're looking at the mandible from the back, and this muscle that attaches from the back of the mandible to the hyoid, the geniohyoid. Notice the names reflect where attached: the genial tubercles and the hyoid bone. Then you got the mylohyoid, but mostly the geniohyoid is a muscle that sleep people are super interested in, right? And there are two of them. The two geniohyoid muscles attach to the inferior genial tubercles on the inside of the mandible. So just think there are two superior tubercles and two inferior tubercles. The mylohyoid muscle similarly also attaches to the mylohyoid ridge on the interior surface of the mandible and then it goes down to the hyoid bone, mylohyoid. That pulls everything up. This allows you to pull your tongue forward because the hyoid bone is the base of the tongue, right? As the mandible advances, it pulls the geniohyoid and mylohyoid muscles forward, thereby opening the pharynx. Got it? So this muscle is critical, and there are some actual incredibly stupid electric things that they put in that force people to contract their geniohyoid while they're sleeping, and instead of putting the jaw in the right place, conditioning the muscles so that they stay there when you're sleeping. This is what we do with TMD patients. We teach them to go into their correct anatomical position, and then through exercises and repetitive exercises, the person learns to stay forward even when they're sleeping. So again, the hyoid is the insertion of both the geniohyoid and the mylohyoid muscles so that the hyoid bone is also pulled forward when the mandible is positioned forward. Everything's coming forward with your MAD, your mandibular advancement device. So I kind of think of it as physically opening up a bag. So if you look at this like shopping bag, it's opened. Someone had to open it and form it to this like this in order for it to stay the way you see it. And I got circled, basically mandibular advancement pulls that whole inferior hypopharynx, everything in the lower pharynx forward and open. But then you have to say, what the heck is causing the collapse of these structures? You know, what is happening physiologically? What is happening developmentally? And when does this all start? And you're going to be super surprised. It starts at 2 years old. It's like, and pediatricians are so conservative that they very often don't want to touch their kids, even though the kids may walk in with faces that are screaming, I can't sleep, I can't breathe. They do allergic salutes, they got panda bear, allergic shiners, they've got all kind of stuff in there. Their clavicles are twisted forward and they don't look. But these things are preventable, and certainly doing airway dentistry is fantastic, but I want you to get a full, complete picture of what you're actually doing. I did give a lecture for the Academy of Dental Dentistry, I think in 2003, on TMD and sleep. And man, I'm telling you, it's one organism, one person. And there are many different things that occur. And to think, oh, I'm a dentist, so I expand the back. Excuse me, there's more going on than that, right? Sleep disturbance are everywhere with TMD patients. They appear to be more and more common in children. And so we need to intervene. Airway dentists treat children, I hope, mostly. That's the best time to treat them, between 3 and 8. When you get them at 12, 13, their bone is more formed, and it doesn't want to be moved as well as when they're growing. But sleep disturbances cause lots of signs and symptoms. One of them is tension-type headache. That's TMD. Irritability, lack of energy, fatigue, and brain fog. They're not motivated. They have anxiety and depression because they don't get enough oxygen to their brain, and the brain is freaking out. They have attention deficits because, again, they don't have any oxygen. Lack of concentration, reduced vigilance, long reaction times. They're very distractible. That's the ADHD kid, isn't it? A lot of the kids that we treat, when we treat them and open their airway, they get better. They're just human beings after that, instead of running around all over the place. These people with sleep disturbances, adults or kids, they're very restless, lack of coordination, poor decisions, increased efforts or errors, all right? The truck drivers, forgetfulness, heart attack, obesity, and diabetes. These are all serious, serious things. And it does relate to the headaches that TMD patients have. And guys, kids have headaches too. And the pediatricians associate that with growing pains. And it's not. It's skeletal imbalances. Whenever there's pain, the body is signaling there's something wrong and it wants the behavior to change. I have this here to show the entire maxilla. And when you have retruded teeth from a skeletal problem, It's a skeletal problem. I mean, it's a skeletal problem. The entire maxilla in one dimension is too retruded or too far back. What does that do? Well, look, there's an extension up in the nasal area. So as that maxilla goes backward, the soft tissue of the nose bends and you get a bump. You can see it. And the anterior nasal spine goes back, and you've got everything going back in the patient's skull and compressing the back of the airway, decreasing breathing ability too. There's a length to that nasal area, the ethmoid area, and if you're compressing everything, there are going to be changes. But most TMD patients have retruded maxillas due to a lack of forward tongue pressure throughout their developmental period, and usually as adults. And remember, the mandible follows the maxilla. So listen, if the person bites into maximum cuspation wherever it is, and it's retruded, the entire mandible bites backward. It hangs forward during the day, but bites backward when it has to bite, jams both of the temporomandibular joints, because the temporomandibular joints are part of the entire mandible, right? You got the two condyles, mandible teeth, all one part. So when the teeth have to protrude to go into maximum cuspation, it jams both of the joints, and over time causes destruction of the internal contents, especially the articular disc. I really like looking at faces. Da Vinci had analysis of faces so that he could paint beautifully and reproduce them. I started doing fixed orthodontics in '82, and my first case was a Filipino girl. And they have square arches. Their faces are not the same. And it drove me crazy because I had to sit and think. I had to bend my wires differently. Everything was different. But what we want to do is look at faces, look at how the faces, all the different changes in the faces, and ask yourself, how did that change occur? But if we look at the young female on the left, she's pretty protruded. The nose is straight and straight across too. It's flat on the bottom. The lips are forward. She could have a little bit bigger upper lip, but that's all full forward. Although her neck is bent a little, it's a beautiful lateral view. If we look at the gentleman in the top right, oh my God, he has no jaw. Notice his lips are apart, and he's starting to develop a bump on his nose. So this is a problem, and I think he's shown post-surgically where they tried to move everything forward and they put an implant in his chin to make it look more vertical, but his airway is maybe slightly changed. We also see this with a young lady on the bottom, and before her, you see the lines on the side of her cheeks, you see the mandible back, lip twisted forward, the bottom lip has to purse forward, and after the surgical, she's more straight, although she doesn't have a long lower face. So we want to look at faces. I might make a video just on that because it is kind of an interesting thing, because the face, they say that the character of a person is imprinted on their faces over the years, and that's absolutely true. And the anatomy underneath is imprinted on the face also. So this is an interesting slide, and it is meant to reinforce the fact that teeth interdigitate, and it is primal. It goes back to reptilian days, maybe even fish. You program in your head, you know exactly where your maximum cuspation is, and you go to it immediately. And it's programmed, it's in there, and it's like solid state electronics, right? It's there. So evolution demands that the upper and lower teeth fit together to masticate food and to create a stable, unmovable base for swallowing when the teeth are in maximum intercuspation. So part of the TMD therapy that we do is reprogramming the mandible to fit into a maximum intercuspation that is artificially created with acrylic. So Once the brain believes there's a new maximum cuspation, it is going to program that mandible to go to that maximum cuspation, which is much more harmonious for both joints, for the tongue, for the throat, for the head. That's the basis. But the key point here is maximum intercuspation is super important to the brain and the body. And there is a programmed spot where it always goes to, and it is programmed. I really like doing demonstrations. So stand up for just a moment. I think we did this one before, but we're going to repeat it and modify it. And go ahead and swallow. Notice that you put your teeth into maximum cuspation if you're normal, right? Your teeth will fit together. Some people have thrusts and other problems. We're not going to get into that. Let's just assume that you go into maximum cuspation. Now, what I'd like you to do is stand up straight, open your mouth, keep it open, and attempt to swallow. Most people can't do it. It's impossible. Why? Because I tried to illustrate in the last slide, maximum intercuspation is needed for swallowing, and obviously you can't swallow if your teeth don't go into that. Again, it's a programmed position, it's neurological and evolutionary. So I'm just making a point here with a retruded maxilla that didn't grow because of swallowing problems, not the tongue not pushing it forward so it can grow. The mandible must actively retrude and posture backward. Remember, there's a rule, evolutionary rule, that the mandible rests about 2-3 millimeters below maximum intercuspation. That's where it rests, not where the muscles are happiest. Not, it's right below maximum intercuspation. These are key points I made. One, maximum cuspation is needed to swallow, and it's evolutionarily programmed in your reptilian medulla oblongata, your brainstem. The rest position is always efficiently right below maximum intercuspation in 3 dimensions. So if you can't one side, can't to the back or upper back, that rest position is going to mimic that maximum intercuspation bite, and it's going to stay there, which could be not very good for the patient. The backward movement of the mandible to achieve maximum intercuspation drives the mandibular condyles into the back of the mandibular fossa and displaces the articular discs, crushes the retrodiscal tissue, and creates nociception. I need to make a quick point, very important. Nociception is when negative information is being sent, emergency to the brain, but we are not always all knowledgeable about all the nociception sent to our brain. So someone has a lot of pain in the joints, they don't seem to have the pain when you talk to them. But as soon as you touch that joint on both sides, it hurts like hell. There have been nociception, afferent means going to the brain, signals continually being sent to the brain, confusing the brain, causing all kind of problems, and this stuff just creates havoc with the brain itself. That's why we see sometimes so many amazing things, including deltoid strength increases with patients who have proper appliances made. So this is an interesting slide. We have the right side of a dried skull. You can see the mandible and the teeth in the front. You can see the coronoid process going up into the zygomatic ring. You can see the ear in the far back, far left, and you can see the condyle. And it's blown up. We're just looking at that small segment of the temporomandibular joint. And we look at it to the right, we have a dried skull. The condyle sticks upward with the neck of the condyle. You see the articular eminence at the front of the mandibular fossa. There's a big dome in there. And notice that there is room and space between the condyle and the back of the fossa, the condyle and the top of the fossa, and the condyle and the anterior portion of the fossa. It's called joint space. In the back, you have the ear. And interestingly, the styloid process is right there on the bottom left corner. These are important things. We'll look down now on the lower left area, and where it's a diagram of the sagittal showing the position of the condyle, and we say that that position is in the 4-7 position, which is the Harold-Gell position, which I believe is the healthiest position for the condyle to live in within the joint. And it's called 4-7 because the 4 and the 7 are inside the condyle as the area is mapped out. On the far right side below, you see that big black arrow, and that is a bad thing, but that's what one of the major pathologies is. That condyle moves into the back portion of the temporomandibular joint. The back portion of the temporomandibular joint is the speaking area. In other words, it's not just a chewing joint, it's not a mandibular rest joint, it is a speaking joint. And speech needs immediate changes and movements, and the mandible is part of that. The tongue, which gives us the word language, lingua in Latin, that is attached to the mandible. Changes in the mandible and the condyle will influence the speech. But irregardless, the condyle moves back and up in the posterior portion of the fossa, and it's not in the 4-7 anymore where it belongs. This is one of the most difficult concepts to teach dentists. It's just impossible. They think if the teeth are gorgeous, orthodontically put together, and a beautiful smile, that's a healthy person. They really do believe that. They do. You do probably too. And it doesn't necessarily mean that the person's healthy. So on this top, we have a maxilla in its correct forward position. The teeth are all bitten together in a beautiful bite. I like the minimal overbite. I like everything. And you look to the left, that particular joint is in the correct 4-7 position. Holy mackerel, this is wonderful. Now on the bottom, you don't see this. You see the same exact beautiful maximum intercuspation created by the orthodontist. And unfortunately, the maxilla is displaced backwards. So if you look at the maxilla on the top and the one on the bottom slightly pushed backward. We have that black arrow in the far right showing it's been most posteriorly displaced. Now, the condyle, which is part of the mandible, goes back into the ear, and we now have crushing of the retrodiscal tissues. We now have nociception. We have they have protective muscle splinting. They're going to move the head around, move the jaw around. All kind of gymnastics are going to occur, even though the bite looks great. But dentists love teeth. Dentists believe in teeth. Dentists say, it must be good. God made those teeth correctly. There is no problem with this patient. Oh my God, is there a problem? Absolutely. So you look at this diagram, and this comes from Dr. William Farah, Bill Farah book. I think it's incredible. You will see people stealing it, and it'll be up there in their books. And they won't even mention Dr. Farah, even though he kind of invented all this. He made sense out of clickology. But again, the mandibular condyles move backward and upward in the mandibular fossa when closing into maximum intercuspation. That's the bottom one we just talked about. Teeth look great, go into their maximum cuspation, but now they're jamming backward. Notice on the far right side, it says reciprocal clicking. Look at that condyle pushing back and up. Two things cannot occupy the same place at the same time. So that displaces the disc anteriorly immediately. And over time, that poor little disc is going to disintegrate because it's getting punched. But when the patient opens, so we're going to look now at the circle on the very top. There it is, biting down on maximum intercuspation. Disc is forward, condyles backward. Now the person opens and the disc slides forward slightly. Then it pops back. See on the diagram C, it's starting to pop back, and you hear a click when it goes back on the top where it belongs. Also separates the condyle from the bone above it, space. And then when they close, it stays on top until it gets close, and then you bite all the way down, it shoves the articular disc forward, out of place, and that's where you begin the new cycle. It's called reciprocal because when you bite all the way down, the disc is out of place, you open, it pops back into place, and then guess what? Later, when you close, it's sitting correctly, but then it gets two things can't occupy the same place at the same time, and it just clicks forward. Very often the opening click is heard, but the closing click is very quiet. You can almost always see it by watching the mandible very closely or using jaw tracking devices, which I have a love-hate relationship with. I believe in the orthopedic philosophy, and I don't think that I don't like machines telling me what to do. I want my brain to do that. That's my best machine. And we're looking at the muscles and the throat, airway, sagittal view. This is a real human being. That's what's underneath the skin that you do not see. And I'm going over something very important. The backward movement of the mandible to achieve maximum intercuspation, which is primal, you got to do it, you're programmed to do it, drives the hyoid bone, which is below the tongue, right, backwards and collapses the airway. Got a black line there showing the stylohyoid ligament. You'll see it in pans. And I'm going to tell you something that you must remember. When you see stylohyoid ligament calcification, it's almost always accompanied with future osteoarthritis and degeneration in the ipsilateral joint. Very important. You can work that out later, but just remember that. But again, the mandible moves back, it collapses everything, it pulls the thyroid cartilage back, it pulls the hyoid back, it pulls everything back, cricoid cartilage goes back. Now you're blocking up the airway. You know, the body is going to protect itself always. And so let's talk about a protective muscle reflex. It's not something that we talk about, but there are all kind of reflexes in the human. A protective muscle reflex is an involuntary muscle contraction. Involuntary. You do not know it. It just happens, guys. You're doing a lot of stuff in your body every day, and you don't even know you're doing it. And a reflex is automatic. So it's an involuntary muscle contraction that occurs automatically in response to a potentially harmful stimulus. You're crushing the retrodiscal tissues. Muscles are going to pull the jaw away in order to protect. Please understand that. It's essentially acting as a defense mechanism to safeguard the body from injury. For example, quickly withdrawing your hand from a hot stove is a classic protective muscle reflex. Very important. Protective muscle reflexes can and often do disrupt the human postural system. So, protective reflex, you hurt your right joint, you're crushing the tissue, you move your jaw, but you also have regional. So you'll stretch the jaw and move your head to the opposite side to stretch the jaw so it won't hit the tissues. Remember this. So your shoulder and your neck are twisted to protect the injured or the joint getting nociception, pain. But I can't say pain because pain is an awareness. You can have nociception, which is harm without awareness. Now, if you say, well, this poor patient who has all this muscle problems, oh my God, the muscles hurt so bad. Well, muscles have a purpose. They're doing something. And if they can't stop doing it, it's usually protecting something else. So the pain is what the patient complains of. So here you go in and you shoot dead the muscles that are protecting the patient's joint. So using things like Botox to reduce muscle pain knocks out the muscle's ability to protect its damaged joint. And this sucks because joints can deal with a lot of degradation and go to hell and not have the kind of pain that a muscle would have. So you're knocking out the protective muscles that are giving pain, Pain is a warning something's wrong. So you should say, what is wrong, rather than saying, let's kill the guy who's screaming. A damaged temporomandibular joint will continue to deteriorate unchecked when its protective muscles are incapacitated. Please understand that once you knock out the protection, you got the warriors, that's the first phase. Knock out the air defenses, let's get the enemy now. Knock out the protective muscles, now you've got damage that is going to freely occur in the joints. An intraoral repositioning appliance will correct the temporomandibular joint malalignment and eliminate muscle pain without drugs and without continued visits for re-injections. And it's expensive. I think they're saying like $500 a visit. It's like a 10 or 15 minute visit. And I can do that with just making a proper orthopedic appliance that straightens everything, supports the joints, and the muscles can relax. Very important concept. Another important concept is, why do neurologists do temporal muscle injections with Botox for migraine? Think about it, guys. That's a muscle. That's a chewing muscle. If that muscle's pissed off, it causes migraine. We know that because migraine can be suppressed with Botox on that muscle. Why don't I just put the jaw, the mandible in the right place, all the muscles relax, and then the migraine goes away, even though it's an indirect relationship. And by the way, the aponeurosis of the temporalis muscle literally goes through the bone into the dura. This is extremely important. Dentists are teeth people. They think about teeth. An exceptional dentist will look up and look at the nose in a panoramic, but they typically don't do that. A person could be completely obliterated, not be able to breathe, have to breathe through the mouth, and the dentist doesn't look up there. And most dentists don't even look at the temporomandibular joints on their panoramic radiographs. Well, let's think, bigger. When you move the mandible, that's going to move the head, right? Because they're switching the weight of the head, left, right, forward, back, and it creates a rock. And where does the rock occur? Oh my God. The rock occurs in the upper cervical spine at dens. Dens is den means tooth, right? Dentistry. Dens, there's a little upward projection from axis, the second vertebra, and that's where you pivot. So when you're moving your mandible, chewing, talking, you're pivoting on that back dens. That's what you do. And the tiny little suboccipital muscles, they act as a guide. And so this is Goucher's work, and it's brilliant. The plane of the teeth goes through dens. You can see that, right? It's like a cephalometric radiograph. And when the person opens, the pivot point stays the same, right? It stays right at dens, because the plane may open, but the person's going to move left and right with their head, and the pivot point stays and remains at dens. Very important. This is why so many people have neck problems. People with TMD problems have neck problems universally. So this is a super interesting x-ray, and obviously the person has their mouth open, right? Now look slightly above the middle. There's like a tooth. There's just a big thing there, vertical lump. That vertical lump is in fact dens. And then on the right and the left, that's atlas holding up the world. So the atlas vertebra spins right and left around dens. That's its job. So when you turn your head right and left. But look, you can see dens when the person opens right through this x-ray. This proves that dens is behind the teeth. Well, we were talking about protective muscle reflexes, but there are also other types of reflexes in the body, and one is the righting reflex. So your eyes are your most powerful sense. They can see a predator, a lion, miles away, and see things before you can hear them, right? It's very important. So the writing reflex requires that both eyes are parallel to the ground, and your head will always be, whenever your head gets disturbed and twisted, your writing reflex is going to put them back. Think about this. That means the body below must contort to make sure, all the way down to the toes, to make sure that that eye sensation, the neurosensory plane, is parallel to the ground. It demands it. That's one of the reasons for the inner ear and your sensation vestibular reflexes. The head has to be oriented straight, up and down, eyes straight. Interestingly, the occlusal plane should be straight. The C1 atlas should be straight, parallel. Very important. So the neurosensory plane reflexes, let's define them. The neurosensory plane reflexes are involuntary. You got to do it. Muscle contractions that occur automatically in response to non-ideal changes in body posture, primarily the head. Very important. The head has gyroscopes. The rest of the body does not. The body follows the head. So these are really critical, key things you should always understand. So the neurosensory plane reflexes can, and often do, disrupt the human postural system. Very important. So if your mandible's to the left and it shifts your head, your right has to contract, right cervical spine has to contract, then there's a reaction down to your hip, right? And it has to contract to level the neurosensory plane. Very important. This is a key concept in understanding whole body pathology, and you want to work with a physical therapist that understands all of this because it's all interconnected. The whole body's interconnected. All right, so some quick statements to punctuate what we were talking about. The head sits on top of the first vertebra, which is called Atlas. Atlas was the Titan condemned by Zeus to always for eternity hold the skies up. And it's also called C1. The mandible is the only movable portion of the head. Very important. When the mandible shifts, it changes the center of gravity upon C1, and all the vertebra from C1 down must respond by rebalancing. This is the B.J. Palmer philosophy, the son of D.D. Palmer, inventor of chiropractic. C1, C2, king and queen determine the shapes of the rest of the spine. When the body misaligns, the head must be repositioned on C1 to align the head regardless of the posture of the body. So the body will have to distort in order to keep the head straight. Just remember, the eyes must be parallel to the ground. The rest of the body must twist or move, compensate in order to make sure that happens. When items inside the body somewhere are injured, there are protective muscle reflexes which distort that body. Those distortions, therefore, create problems with the writing reflex. Now, the writing reflex has to kick in after the protective muscle reflex regionally down the body, and you finally get the head corrected, but all those distortions are now locked in. Guys, this stuff is real. It really is. In Harold Gelb's book, early is one of his first ones, he showed these x-rays that were amazing and almost unbelievable, but true. And I've seen it in practice too. You get a patient comes in, far left, twisted, curved spine. Look at the heavy curving from the sagittal view. He puts an appliance in right then. Please understand, these x-rays are not a week or two later. He didn't go through physical therapy. Dr. Gelb put the appliance in and then retook the full body x-ray. And look at what happened to the spine. It straightened. The curve improved from the sagittal. Everything was better. You can't really do that today, so much radiation. But let me tell you, this is for real. Once you put a MORA in, mandibular orthopedic repositioning appliance, It changes the way C1, C2 balance on the head balances on C1, C2, corrects it, changes the rest of the spine. All the distribution of weights to keep the head in the central axis of the body have been restored. Now you don't need muscles to do it. The spine does not have to be contorted. And this is that comes out of his book directly. So this isn't just one guy, right? This is another book that Alred Fonda wrote, the dental physician. He also wrote this book on the top right, The Dental Distress Syndrome, which people don't read and is the most amazing thing in the world. It's incredible. We have it at the Institute, and basically Fonda went a little further, not only with x-rays, but he took the actual posture. So he takes a guy who's twisted to the left, slouching, he puts his appliance in. Oh my God, look at the shoulders, look at the head. This is immediately after the appliance is put in. I'm trying to teach you this. It's hard to believe it. And then you see the guy from sagittal, much better, non-slumping posture. And on the other side, he has an x-ray of someone he did with scoliosis, and you look at the x-ray taken without the appliance in and the right one with the appliance, it corrects. So I want you to understand, most of this stuff is completely ignored. People do not make orthopedic appliances. They shove people's jaws back and make it hit in a close packed posterior position, jammed against the skull. Please, this is not a good thing. Both of these cases prove that orthopedic philosophy is in fact changing lots of different things. And please remember this, if anything, you're doing a lot more than you realize you're doing when you put an appliance in. The most nasty muscle that I deal with is sternocleidomastoid muscle. There are gyroscopes in right and left ears. There is no gyroscope in the rest of the body. Well, how does the rest of the body know what's going on? By its interconnections. Notice that the sternocleidomastoid goes from the transposes completely across from the skull to the neck to the chest. And it gives information about proprioception to the rest of the body and the central nervous system. This particular muscle is involved very often, and these are trigger point referrals. It's a person with a sternocleidomastoid problem. These little X's are areas of triggers, and look, forehead pain, ear pain. They go to the ENT complaining that they have problems. In fact, the ENT says, you're fine. You must go to the psychiatrist next because you don't have any dysfunction. But yet, the TMD causes a neck problem. Pain behind the ear. Pain circling over and around the eye. And then look at that on the right TMJ. There's pain there from the sternocleidomastoid. Oh my God. And of course, you've got things in the chest, and there's a little cough reflex too with this muscle, and you'll touch the bottom of the muscle and the person will cough. It's kind of cute. And unfortunately, I have a passion for doing that when I see it, and I shouldn't. But this particular muscle is governed by the 11th cranial nerve accessory, and many dentists say it has nothing to do with me. I'm a trigeminal guy. But the cuspids, the vampire tooth, they rip. In order to rip, you must rip the sternocleidomastoid, and you got to pull with the trapezius hard. And the trapezius and the sternocleidomastoid work together with the same accessory nerve in order to assist us with ripping food. So they are related to what we do. This is a diagram that I love. I really do. And it is the Kinney-Funt stack diagram. Visual index is what they call it. And this is used for people to look at patients, and they mark up where their pain is, report it. And it includes most, not all, please understand, there are many more symptoms and signs that we see from TMD. And most dentists, they don't have any clue that these various symptoms could be a problem. So head pain, headache, forehead pain, temporal pain, temporal pain, migraine type. It's not migraine, but it's right over the migraine, and a neurologist, they don't touch. So if you have the person bite down and you hold their anterior temporalis, it tightens, you press on it, that's muscle, not migraine. Sinus type pain, shooting pain up the back of the head. Here, and scalp pain, painful to the touch. Eyes, pain behind the eyes, bloodshot eyes, bulging eyes, sensitive to sunlight, just like migraine, but not migraine. Mouth, discomfort, limited opening, very common. Inability to open smoothly. A jaw that deviates to one side when opening. A jaw that's locked or either shut or open. And the patient can't find their bite. They don't know where to go. And remember, that's a primal thing. They have to be able to know where to go to swallow. Teeth, clenching and grinding at night. Usually that's sleep apnea related. Looseness and soreness of the back teeth. Again, trauma. Shaking baby syndrome. The patient's beating up their teeth and their teeth die. Throat problems. Swallowing difficulties. Laryngitis. Sore throat with no infection. Voice irregularities or changes. Frequent coughing or constant clearing of the throat, and feeling of a foreign object in the throat constantly. I had an ENT bring his daughter to me, ENT, remember that, throat, and she had constant feeling something in the throat. And I did a full exam with him watching. He was like amazed, and he wanted me to come to the medical school. He's a faculty member, and they wouldn't let me, because the people that taught at the medical school said, well, we're having trouble getting them to understand their own work, let alone new stuff not related to their therapy. I was a holy mackerel. But anyhow, we'll continue. Neck problems, always. Lack of mobility, stiffness, neck pain, tired sore muscles, shoulder aches and back aches, and arm and finger numbness and or pain. Oh my God, that took me a while to figure out. It's thoracic outlet syndrome. Basically, the nerves and arteries to the arms are getting strangled. Jaw problems, clicking, popping jaw joints, grating sounds, crepitus, pain in the cheek muscles, and uncontrollable jaw and or tongue movements. We see a lot of movement disorders that can be, I've cured stuttering. I have, right? I've tardive dyskinesia, 2 cases, cured. We never talk about this because we never have dialogues with anybody else. We're dentists. We do teeth. Ear problems, hissing or buzzing or ringing, tinnitus, decreased hearing, ear pain and earache, no infection. 50% of ear pain is occult. They don't know what causes it. Clogged, itchy ears. And then finally, very interestingly, vertigo and dizziness, because the postural nervous system gets messed up when the mandible is tight and not moving around correctly. So I want to illustrate this term because I use it a lot and people don't understand it. No, you say, oh, that's pain. Nociception is pain. No, it is not. No, it's not. Pain is a nociception, but not all nociception is pain. All right, so pain has an emotional content and an awareness content. But joyous stimuli do not always have to come to conscious levels and create an emotional problem. So there's pain without perception. Interesting, but I can't use that word pain, but you like the word pain, so I use pain. It's bad to use because pain always has an emotional component. So what is nociception? It's the perception of a painful, that's awareness, or potentially injurious stimulus. So it comes from Latin noci, which is a combining form of nocere, to do harm, from the Latin recipiere, to take to oneself, take in, to emit, to receive, or back, cipiere, combining form of capere, to take or capture, right? To take in, sense, or grasp that there's a harmful stimulus. It's nociception. Learn this word. So you can have nociception in the joints with no awareness. So a quick note about a quick note about the mandibular rest position. So the mandibular rest position is always a few millimeters right below maximum incruspation. So the body lets the jaw hang a few millimeters, always directly below maximum intercuspation. This is efficiency. This is programmed. You can't change it. It's part of the reflexive system that we have. So the mandibular rest position is always a few millimeters below maximum intercuspation, and there's a pure mandibular rotation. Remember we said the jaw rotates and translates. It does those two motions. But when it hangs, it's just immediately below maximum intercuspation and then rotates up quickly into a bite. And then you swallow. And so there's a pure mandibular rotation to close into maximum intercuspation. And this is a little crazy. I'm just showing you that the right one is a little class 2 backward. So they're going to go in from that bite, which is different from the right one, into that maximum intercuspation, even if it's retrusive. So previously, I emphasized that there are 3 dimensions in the human form, and we forget this. So if we look at the one dimension on the left, that's the expanders. These are these airway dentists that expand the posterior. That's what they do. They're good at it. Patient breathes better. Everybody's happy, except the child continues to grow abnormally, and all the work you did is for nil. Second one in the middle, there is forward growth. The tongue pushes forward also. So when the maxilla grows, the dentition goes out, forward, and the maxilla goes forward, because if you think of the palate, it slopes, right? So when you push, when you swallow and push, that slope gets pushed on and the bone moves forward, and you get forward development of the maxilla from the tongue. And there is a third dimension, right? You got width, height, and that's height. 3 dimension is height. So the vertical position of the maxilla down, up is important also. So we look at that bone moving left, right, front, back, tilting, but it also has a vertical component. And you see that with collapsed faces. Very important. Costin, ENT, wrote one of the first articles ever, the Costin syndrome. It's not a syndrome. Anyhow, he talked about the loss of vertical dimension of the face, a collapsed bite, and causing huge amount of things. And that's what needs to be considered also. That's the third dimension. Now, do orthodontists think about vertical dimensions? They don't. They move teeth around in single planes usually. They may put elastics on, right? But it's not a controlled thing where they're moving, correcting a canting jaw. They just don't do that. And we need to think differently. The problem is, when I start talking to orthodontists, this is not something that interests them simply because it's just a lot of work, and they're going to have to charge for a lot of work, and it's not practical in their opinion, and they weren't taught that. So we get into this difficulty. But again, I'm saying with TMD patients, you must treat the maxilla the way nature does, and the mandible also, in 3 dimensions. People always argue with me, does posture and neck position have anything to do with occlusion? Most people say no. Dentists are teeth doctors. So let's do this. Stand up and tap your jaw together several times. Bang, bang, bang. Okay. Now move your head back as far as you can and do tap, tap, tap several times. Okay. Go back to your head straight, bend forward, tap together several times. Go back. Move your head to the right, bend your head to the right, tap, tap, tap. Go back to the center, move your head to the left, tap, tap, tap. I think you will now believe that posture does in fact change the mandibular position, because it does. You can see it. You just did it. So changes in posture do influence occlusion, particularly over time. We can't forget this. So if a person has a forward head posture, There's just a lot going on that you may not understand, you know? And what's always amazing to me is dentists will put restorations in when a patient is laying back and even the mandible is not biting correctly, but they'll do their adjustments with the head backward, when in fact, the patient's standing and they're closing from rest into maximum anticipation. That's where the adjustment really should primarily be, but we don't do that. We should, absolutely, with dentures. This guy was brilliant. He was one of the first, he was an ENT, but he was brilliant. He kept on asking questions, even though they didn't influence his particular specialty. And he asked the question, do a lot of the head and neck problems that we see, like with many ears, did they have anything to do with dental? And Costin syndrome is described with lots of different things. And he wrote a paper. The paper was entitled "A Syndrome of Ear and Sinus Symptoms Dependent Upon Disturbed Function of the Temporomandibular Joint." Got it? Very important. It was published 34 in the Annals of Otology and Rhinology and Laryngology, and it was a breakthrough paper. They no longer consider it important. ENTs kind of know of this, but when you send them the paper or talk to them about it, it's not important. But it is to us. It is extremely important to us, and it proves a lot of my points that a lot of the symptoms that TMD patients have come from their mandibular malpositioning and their joint malpositioning. But it's not just a joint. You see, he was focused on the temporomandibular joint. It's actually mandibular position that creates the pathology. So here we go. This guy is saying, well, when the mandible's not in the right place and the joints are jammed, these are the things that happen to my ENT patients. They have impaired hearing. This is a published paper. Lots of work continues since this. Everybody ignores it. Dentists don't teach it. Dental schools don't teach it. What the heck? The ENT profession, they now think that's not their domain. But yet, this stuff is seriously important. So he said, impaired hearing, continuous or with intervals of improvement, stopping or stuffy sensation in the ears, marked about mealtime, tinnitus, usually a low buzz in its type, less often a snapping noise with chewing, pain, dull within and around the ears, ear pain, that's why he sees the patients, dizziness, mild, again attacks of prostrating severity, not prostrating to get on the floor, definitely relieved by inflation of the eustachian tubes. Well, I can't get ENTs to inflate eustachian tubes. What is the eustachian tube? It's the tube from the middle ear to the back of the nose, and it equalizes the pressure in the middle ear. But when you have allergies, it blocks up, the fluids back up, infection occurs, and they poke through the right part of the ear rather than doing the allergies that were causing the eustachian tube to block up. It says alleged sinus symptoms, headache, severe and constant headache, localized to the vertex and the occiput and behind the ears. Typical site, posterior sinus pain, but increasing toward the end of a day. Atypical sinus history, suggestive of eye headache, burning sensations in the throat and tongue and the side of the nose. Guys, this is all TMD. Guys, your dental stuff is influencing these signs and symptoms. Don't ever say that what you do isn't important. You just need to expand your knowledge and understand that all of these symptoms are related to your teeth and your joint position, and you can help these patients. I actually just read a book recently on TMD, and the expert in the chapter said that Costin had to do with occlusion. No way, not at all. He mentioned teeth touching, but that wasn't the problem. It was the vertical dimension. So Costin syndrome, 1, a lack of molar teeth or badly fitting dental plates permitting an overbite. Now, again, years ago, we didn't have fluoride, and there were very few dentists. So a lot of people have missing teeth. Dentures. When I was first graduated, '82, there were plenty of denture patients. Now, a lot less. 2, mild catarrh deafness, catarrhal deafness, improved at once by inflation of station tubes. Try to get an ENT to inflate these station tubes today. He did this all the time, right? This is part of his protocol. And when the mandibular condyle goes backward, the most medial aspect affects the station tube by compression. Very interesting. So it causes 3, dizzy spells relieved by inflation of the eustachian tubes. 4, tenderness to palpation of the mandibular joints, TMJs. 5, marked comfort to the patient from interposing a flat object between the jaws. That's our appliance, except we've refined that to be exactly correct. 6, the presence of typical headache after sinus or eye involvement has been corrected. Still headache. Presence of the typical headache when sinuses or eyes are found to be negative. Now, one thing I do want to say, it's really important, the dentist he worked with was a guy named Willie May, M-A-Y, and he used the swallow technique to take his bite. It's really interesting, and it worked very well with him. Dr. Costin had a dentist. You have to go out and find the ENT. It's going to be difficult. It's just this is the way it is. I think it starts best with social interactions, and then eventually friendship, and then eventually professional. It's just the way that works in life. But you need to find an ENT that you can work with. You'll notice these pictures on the far left, normal vertical height, collapsed after the bite or dental wear from tooth root. The one in the middle, that's the TMD patient, that's the Costin syndrome patient, and even worse, you've got the really badly worn denture case, complete collapse, tip of the nose is touching the chin, the mid face is collapsed. This is what happens, and this is what he is talking about. Vertical dimension. Got it. Very important.
Functional symptoms, such as clicking and locking, are some of the most frequent findings in patients with temporomandibular joint disorders. Both the normal and pathological anatomy and function of this joint has caused a lot of speculations. Can you, Dr. Eriksson, review the anatomy of a temporomandibular joint?
This is a sagittal section of a right temporomandibular joint. Here you can see the condyle, the fossa, and the tubercle. This is a disc. And here you have the upper joint compartment and the lower joint compartment, filled with blow water in order to stabilize the disc during sectioning. The soft tissue cover on the condyle is thin. This is probably an artifact. And it's also thin in the fossa and somewhat thicker on the tubercle. The posterior band of the disc is situated superior to the condyle. The posterior attachment is a little bit thinner and longer than seen in an absolutely normal joint. The lower head of the lateral pterygoid muscle is seen here, and this is the superior head. The knowledge of anatomy is essential for understanding of joint pathology. During orthography, we have learned that the function of the joint is also very essential. Which are the possibilities to study joint function?
Arthrography, surgery, and arthroscopy can give an impression of the function of a joint, but it is far from easy to understand the complex function of this joint by observing it through a surgical opening or through a thin arthroscope. Videotape recording of arthrography is probably the most effective way of studying joint function today. This technique is, however, not optimal for educational purposes, since the interpretation of the arthrograms requires some training. Dr. Isberg and myself studied the course of clicking temporomandibular joints in autopsy specimens by the aid of high-speed cinematography. This gave Dr. Eriksson and myself the idea of making a videotape of functional alterations of a temporomandibular joint. This is a normal temporomandibular joint. The disc is biconcave and it's located in a superior position. The central thin part of the disc is consistently lying in between the condyle and tubercle. During opening, there is rotation in the lower compartment and more of translation in the upper compartment. In this joint, the disc is also located in a superior position. The disc is biconcave, with its posterior thick part located on top of the condyle in the closed mouth position, and posterior to the condyle at maximal opening. There is, however, a small perforation in the central part of the disc. During opening movement, there is rotation in the lower compartment and more of translation in the upper compartment. There were no crepitation or clicking from this joint during movement. The location of a perforation to the central thin part of the disc is relatively unusual. In joints with disc displacement, it is our experience that perforations usually are located in the posterior attachment and not in the disc proper. When the condyle is distracted downwards from the temporal component, the perforation can be clearly seen. In this joint, the disc is anteriorly displaced and it's reduced on opening with a click. These joints demonstrate reciprocal clicking, which implies clicking during opening followed by clicking during closing. The disc is here again anteriorly displaced. The configuration of the joint compartments corresponds very well to what has been seen on arthrograms and to observations during surgery. Reciprocal clicking is a clinical sign of anterior disc displacement with reduction. In this joint, the disc is biplanar. It's located on top of a condyle, but during opening it's slightly displaced medially, and in association with this displacement, clicking was registered. The posterior attachment between the disc and capsule is considerably thinner than in a normal case. During closing, the disc is again replaced to a more correct position between the condyle and temporal component. The disc is lying in between the condyle and temporal component, but there is a type of reciprocal clicking caused by a mediolateral movement of a disc. The next joint has a medial displacement of a disc. During opening, the disc is moving in lateral direction, and here the disc can be seen. Now it's displaced medially anterior again. And here it's replaced to a more normal position and displaced again. Clinically, it can be difficult to differentiate the pure anterior displacement from an anterior or anterior medial displacement. The next joint demonstrates anterior disc displacement without reduction, which implies that the disc is consistently lying anterior to the condyle. During all mandibular movements, the disc is lying anterior to the condyle, and at maximum opening, the disc is folding downwards as seen here. There is a considerable stretching in the posterior disc attachment at maximum opening, and even if the disc is displaced, there can be a good range of motion due to deformation of the disc and stretching of the posterior disc attachment. The next joint demonstrates a large perforation of the disc. There is only a small piece of the disc remaining anterior to the condyle. This joint demonstrated crepitation and irregular movement.
So I hope that video played. If not, it's the yoint video with a Y, Y-O-I-N-T, yoint, because that's the way these guys pronounce joint in English. But it's on the Atlanta TMD Institute website, so you should be able to go to the website and enjoy it. I think the video is instructive because it teaches you about all the soft stuff that's inside that joint. All right, the Atlanta TMD Institute, TMD treatment protocol. Just a brief, quick outline. 1, person comes to us, first thing we do is acute symptoms, things that are immediately causing problems, primarily pain, myositis, TMJ arthritis, myalgia, muscle relaxation with a 6-week TMD program. I believe in supportive therapy, not just dental appliances. And then if it's a closed or open lock, we want to deal with that, get them working well. Sometimes I make something called a Smurf appliance. It's blue, and if I can't get the patient open enough to get a lower impression, make a soft guard, I'm going to put this jig in there made out of blue vinyl, which will hold the patient apart. Then, when acute symptoms are relieved, we go after chronic structural and functional problems. We're treating the third dimension, with first, second, and third dimension, with a MORA, mandibular orthopedic repositioning appliance. What are we treating in chronic structural and functional? Posterior displaced condyles, center of gravity dispersions of the head, mandibular asymmetry, facial asymmetry, mandibular rest position, very, very important. We're treating clicking and popping, tinnitus, benign tremors, very common with TMD patients, very often is eliminated, movement disorders, brain fog, trigger point therapy with the muscles. Then we treat perpetuating factors, factors that could cause that TMD to continue. 1 is insulin resistance, the #1 criminal. 2, type 2 hypothyroidism. These people have normal TSH but yet they have all the signs and symptoms of hypothyroidism, including muscle dysfunction, respiratory allergies, food allergies and intolerances, breathing disorders. These are very important. Then we go after the cervical spine, right? Or actually mouth breathing and hyperelasticity, joint laxicity, like with Inlos-Danlo. Then we move down with the physical therapist and we go after cervical spine disorders, appropriate manual hands-on therapy. Limited cervical range of motion is treated. We want it to be normal. We treat the military neck, the kyphosis, and thoracic outlet syndrome. And this is all treated without the aid of a chiropractor because if you remember the theory, when C1, C2 are fine, the rest of the spine will correct. Sleep disturbances, extremely important. Everyone seems to have them. We put a modified Farah appliance in. Dr. Farah was from Montgomery, Alabama, one of the most brilliant people ever. He used an upper appliance. I don't like that. It interferes with speech and it has a ramp, so it looks like you get this big tooth. Even though I think he was in the right direction, I don't have to physically reposition my patients. I have them neuromuscularly program themselves. And so we make a TMD sleep appliance, modified Thera. Musculoskeletal imbalance, listen, these patients should correct their forward head posture, their wing clavicles, their backs, and everything through balance training and weight training throughout the rest of their lives. Breathing disturbances, almost all these patients can't breathe correctly. They don't use diaphragmatic. We use the Butenko method. Then special care. We have to send off our sleep study. We have the ENT open the nasal aperture only after allergies are taken care of. Abnormal swallows, the myofunctional therapist helps us there. Abnormal speech, the speech therapist helps us there. True migraine and abnormal cranial exams would be treated by the neurologist. Tumors, the maxillofacial surgeon, I've had that. Rheumatoid arthritis, psoriatic arthritis, gout, any of the arthritis would be treated by a rheumatologist. But we work intimately with them all. It's a combined effort. I believe strongly that we can heal people, and we do it every day at the Institute. I hope the Institute is there after I pass away. I've written many books, 8 books, soon to be another one, and they're free. You can't get them until you read them. And the etiology book is the most important one. We provide that for free. That's part of our mission to help healthcare professionals understand TMD and help patients. Primarily focused on dentists. I'm a dentist, but we need ENTs on board. We really need ENTs on board. We need them desperately. We need physical therapists on board. We need them desperately also. But good luck in your endeavor. Thank you so much for watching this video to the end.